cholesterol goal in 2023. Now, there is strong and consistent evidence from multiple lines of evidence showing that LDL cholesterol is causal for atherosclerotic vascular disease. For this reason, it is the primary target in the guidelines, and LDL cholesterol goals have become more stringent than ever. Here you see the most recent guideline where we recommend at least a 50% reduction from baseline for those with high and very high risk. And the ultimate goal is less than 1.4 millimole per liter or 55 milligrams per deciliter in very high risk. We even have lower goals for patients with recurrent events. So how do we get to these goals? Of course, lifestyle and statins are the backbone of therapy, and we can add ezetimibe as well. But we still can have patients not at goal, intolerant or non-adherent to statins. So we have a new group of agents, lipid-lowering agents, which I will discuss today. Statins block HMG-CoA reductase and eventually increase LDL receptors, increasing LDL clearance. They do have some pleiotropic effects at very high doses, but we think that the main effect decreasing cardiovascular events is significant LDL lowering. If we use high-intensity statins, we can get at least a 50% LDL cholesterol reduction with atorva 40 to 80 or rosua 20 to 40. But not all patients are taking these medications properly. We know that there is a linear relation between LDL reduction and cardiovascular disease. For each 1 millimole reduction in cholesterol, MACE is reduced by 20%. But we also know that, at least in Europe, only a third of the patients are using high-intensity statins that can lower LDL by 50%. We know that the cardiovascular benefits of statins far outweigh the risks of adverse events, and dysglycemia and muscle symptoms are seen. But unfortunately, especially the muscle symptoms decrease adherence, and the prevalence of statin intolerance all over the world is thought to be around 9% in a large meta-analysis. We also know that not all the reported muscle symptoms are due to the statin, and there is a large placebo or nocebo effect. In randomized trials, 90% of all muscle symptoms actually were not due to the statin. Nevertheless, in clinical practice, we really have to deal with these patients and talk to them. And if they're not able to take the full dose statin, decrease the dose, switch the statin, or use additional therapies. Ezetimibe is our first choice because it lowers LDL cholesterol by 15 to 20%. It's cheap and safe. It was the first non-statin to improve cardiovascular outcomes in the IMPROVE-IT trial. We also know that if we add ezetimibe to a statin, it lowers LDL cholesterol more than just lowering, but than just increasing the dose of statin. The recent racing trial looked at the efficacy and safety of moderate intensity statin plus ezetimibe and compared it with high intensity statin monotherapy in patients with atherosclerosis. In this trial, combination was non-inferior to high-intensity statin monotherapy, and more patients on combination got to goal because there was lower intolerance-related drug discontinuation or dose reduction. It has also been shown in a retrospective analysis of 300,000 patients that fixed-dose statin ezetimibe combination works better than a separate pill combination because of increased adherence. The new drug that we started using is bempedoic acid. it inhibits ATP citrate lyase. This is an upstream of HMG reductase in the cholesterol pathway. It's a prodrug, and it cannot be activated in the muscle, therefore does not have any muscular side effects. It also has a second action, activating AMP-activated protein kinase, therefore improving glucose tolerance and reducing high-sensitivity CRP. In a pooled analysis of phase 3 trials, bempedoic acid reduced LDL by 18% on top of a statin and 25% without a statin. This year, the first cardiovascular outcome trial of bempedoic acid was announced. This was the largest statin-intolerant patient trial in patients with high risk, unable or unwilling to take statins. And in this trial, bempedoic acid compared to placebo reduced LDL cholesterol by 22%, reduced cardiovascular events by 13%, and there was no increase in diabetes. There was also a pre-specified primary prevention analysis, and in these patients, the risk reduction was even higher by around 30%. It is also possible to have bempedoic acid ezetimibe fixed dose combination, and in a randomized trial, this combination reduced LDL cholesterol by 36%. Now, what are the advantages? It is a cardiovascular outcome trial. It's a good option for prevention, especially in statin-intolerant patients. It doesn't increase myalgia or diabetes, but it does increase uric acid and gout and cholelithiasis. What about PCSK9 inhibitors? PCSK9 monoclonal antibody inhibitors are the most potent agents we have today. In 2 big trials, they reduced LDL cholesterol by 60% and also were able to reduce Lp(a). These 2 big trials, Fourier and Odyssey outcomes, also showed significant reduction in cardiovascular outcomes on top of lipid-lowering therapy. The subgroup analysis from these trials have shown us that patients with recurrent MIs, multi-vessel disease, peripheral arterial disease, high Lp(a), large number of vascular beds affected, and coronary artery bypass surgery benefit even more. There was an extended follow-up of the Fourier trial called Fourier Open Label Extension. And here we see that patients originally in the parent trial had a 15% lower risk of MACE, showing that cardiovascular risk continues over years and increases. Also, this trial showed that the lowest LDL group benefited the most. There was no J-shaped curve or no threshold for benefits like in hypertension trials. Long-term safety was also reassured in the open label extension. Patients who had an LDL cholesterol of around 30 milligrams per deciliter for 8 years had no increase in serious or other adverse events. We also now have evidence from imaging trials. Sophisticated imaging trials have shown us that after an acute coronary syndrome, lowering LDL cholesterol significantly by PCSK9 monoclonal antibodies increases the fibrous cap thickness, decreases the lipid content. So both the Huygens and Pacman trials prove that it is able to stabilize the plaque and also acts very fast when you have a need for speed after an acute coronary syndrome. So the advantage with monoclonal antibodies is that it decreases cardiovascular events. It's the most potent and fastest way of lowering LDL with long-term safety. The major disadvantage is the cost. Also, some patients do not adhere to monthly or bi-monthly injections. We also have a new PCSK9 inhibitor, which is inclisiran. This is a small interfering RNA going to the liver and blocking its translation. It is possible to administer only twice a year, and a large number of Orion studies are exploring the efficacy and safety of inclisiran. We also have already the pooled analysis of phase 3 studies, Orion 9, 10, and 11. And these studies show us that it is possible to lower LDL cholesterol by 50% with inclisiran dosing. And except for injection site reactions and some bronchitis, there was no significant adverse events. We do not have the cardiovascular outcome trial for inclisiran yet, but recently this year, there was a patient analysis of the patients on phase 3 trials. And this analysis showed inclisiran to be associated with a 26% lower probability of MACE. Of course, this analysis was not powered for outcome, but it shows us that probably the outcome trial has a high likelihood of being positive. The long-term efficacy and safety of inclisiran has been reported in the Orion 1 and 8 trials, and in long-term 4-year follow-up, apart from injection site reactions and a few liver adverse events in patients with underlying liver disease, there were no significant concerns. So the major advantage here is having only twice a year dosing and lowering LDL 50%. It has already been approved for primary and secondary prevention, but the cardiovascular outcome trial is still pending. And just like all new medications, the safety data is now limited for chronic kidney disease, liver disease, pregnancy, and heart failure patients. What is coming up? So these were the medications we already have available, but there's some two interesting molecules coming up. First of all, for the first time, it was possible to synthesize an oral PCSK9 inhibitor. Before that, these were not bioavailable, but a new synthetic peptide, very small in size, is resistant to gastrointestinal degradation. It is poorly absorbed, but requires a permeation enhancer. But it can be taken orally every day. And in a phase 2b trial, it reduced LDL cholesterol by 60%, and at least in the early stage, was well tolerated. So now a phase 3 trial is starting. These agents all work for patients with LDL receptors, but we have the homozygous patient with minimal or no receptor activity. And apheresis and lometibide were the only choices until recently. But now we have a new agent for these patients, and that is the angiopoietin-like 3 inhibitors. Evinacumab is a monoclonal antibody against angiopoietin-like 3. And in the ELLIPSE study in 65 homozygous FH patients, monthly injections decreased LDL cholesterol issues and decreased triglycerides for our patients. And in the new consensus paper of the European Atherosclerosis, recommend this as an additional combination therapy in homozygous FH patients. The final agent I'm going to remember that raising HDL by and with some of these agents, there were compound-related off-target toxicities. So the next hope is CETP inhibitors that really lower ApoB and LDL cholesterol to much higher extents than the previous ones. And this agent is called obicetrapib. In the ROSE trial, in dyslipidemic patients, it lowered LDL cholesterol significantly by more than 50%, and surprisingly, it also lowered Lp(a) significantly. And now it is possible to have it as a fixed dose combination with ezetimibe. And this obicetrapib-ezetimibe combination reduces LDL by 63%. Of course, these are all early days. So far, so good in terms of toxicity, but we have to wait for the phase 3 trials. So we have so many to choose from. But the way to go forward is, what is the percent lowering needed to get to goal? Because we know that high-intensity statins reduce LDL by 50%, but by triple combination, you can go down by 85%. We need to ask for the patient preferences and adherence and side effects. And of course, each country has their own reimbursement policy. Just one small example from Europe, the Santorini is the most recent real-life registry looking at LDL goal achievement in Europe in primary and secondary care settings. The Santorini study published this year showed that even although they need it, 21% of patients in Europe are not taking lipid-lowering patients, and 54% are taking just statins, and combination therapies taken in around 24%. And that is why patients are usually not at LDL goal. And when you look at LDL goal attainment, it's 20% in Europe and 18% in very high-risk patients with atherosclerotic vascular disease. So we can conclude that LDL cholesterol is causal for atherosclerosis and should be lowered to guideline-recommended goals. But guidelines are really under-implemented in life, and greater use of combination therapies are needed to achieve goals, especially in patients with higher risk. Thank you for your attention.